Greetings, everyone. My name is Rohit Bhargav from University of Pittsburgh. I'm the meeting secretary for the International Society of Breast Pathology. And together with the president of ISBP, Dr. N. Solomon, I welcome you all to the first online webinar for ISBP. Unfortunately, Dr. Solomon is unable to attend due to family emergency and sends her apologies. Before we begin, I would like to mention a few housekeeping items. This is a webinar, not a Teams meeting, so your video and audio has been disabled. If you want to communicate, then please post your question or comment in the chat section. After the lecture, I may be able to unmute you, but I still recommend you post your question in the chat. If the webinar is interrupted for any reason at your end, for some technical reason, please log back in using the same link. If I get disconnected, I'll do the same. Hopefully this will go on smoothly. The webinar is open to both members and non-members, but we are recording the webinar today, and the recording will be posted on the ISBP website and will be accessible to the members. So now let's begin the webinar, and I'm very excited to introduce our speaker for today, Dr. Caterina Marchio. Dr. Marchio is an experimental pathologist leading the research program of the pathology unit at the Candiolo Cancer Institute in Turin, Italy. Dr. Marchio obtained her medical degree at the University of Turin in 2004 and completed her PhD in 2008 after working in collaboration between the University of Turin and the Breakthrough Breast Cancer Research Center in London. She has been a visiting researcher at Memorial Sloan Kettering Cancer Center in New York in 2014 and a visiting professor at Institut Curie in Paris in 2018. Her research interest spans from histopathogenesis of breast carcinoma to molecular pathology of breast cancer and genetics of HER2 positive and HER2 low carcinomas. Her specific interest in HER2 equivocal breast cancer has been funded by the Italian Association of Cancer Research. Dr. Marchio's talk is titled HER2 Testing in the Era of Antibody-Drug Conjugates, a very timely topic. So without further delay, I will hand it over to Dr. Marchio.
Thanks, Rohit, and thanks a lot for the kind introduction and for the invitation. And this is also extended, of course, to Anne, who unfortunately cannot be here today, but of course, thanks to both of you. So I'm going to be sharing my screen so that you can see my talk. Right. Okay. Okay, I think you should be. I'm now in presentation mode. Rohit, could you please just confirm that you can see the slides?
Yes, I can see the slide.
Perfect. Okay, thanks a lot. So, hello everyone. Today we decided to, as Rohit mentioned, to talk about a very timely topic, that is the shift that we are witnessing at the right moment in HER2 testing, from HER2 addiction to another type of testing that is useful for the prescription of antibody-drug conjugates in breast cancer and beyond. Here you can have a look at my disclosure. Without further delay, I'm going to be showing you my outline for today. So, of course, if we talk about HER2, that has been, and it is still the main character in breast cancer, especially in the context of precision medicine for our breast cancer patient, we're going to be starting from, remember a little bit about the concept of HER2 addiction in breast cancer. And then we will shift to the fact that we managed to exploit HER2 a little bit as an escamotage, just because it's a receptor that is on the surface of tumor cells. For something else. And with that, we need to talk a little bit about the concept of HER2 low and now ultra low breast cancer and how we assess these carcinomas. But I do think that in the era of prescription of ADC, we need to start a little bit thinking about whether it is just all about the presence of HER2 and its degree of expression on the tumor cells, or whether we should also be focused as pathologists and as translational researcher scientist in a way on the type of biomarker analysis that probably we need for this type of scenario. So I want really with this talk also to have a critical view on what we need for really have a neat overview of the best candidate for ADC prescription. And I will, of course, talk in this context always on breast cancer, but I will be also mention a little bit, I will touch a little bit also on other type of carcinomas, because actually for a specific ADC, we have now an agnostic approval by FDA. So recently this year, I had the opportunity to overview a little bit the past, the present, and the future of breast cancer and how pathologists enter in the field of breast cancer prognostication and prediction of response to therapy. So I drew actually this roadmap that was meant to be like, you know, a kind of historical overview of what we have been doing for our breast cancer patient and what we are going to be doing probably in the future. Of course, it's all always starting with histology and immunohistochemistry, which actually are really the cornerstone of our everyday diagnosis. But then in this roadmap, you see that we have been adding over the past, I would say 20 years, prognostic signature, then the contribution of next generation sequencing, especially in the metastatic disease. We have added PD-L1, we have been talking about BRCA testing, and then we had to reshape a little bit the way we test HER2. So HER2 has been a powerful biomarker in the 90s for the identification of HER2 addiction and the prescription of trastuzumab and other anti-HER2, classical anti-HER2 agent. And now we have to, I usually say that we have to rethink HER2 in a different way. And so here we introduce the low levels of expression of HER2 in breast cancer for the prescription of ADC. So it is really a journey from HER2 addiction to the consideration of the whole spectrum of HER2 expression. Here you have a cartoon depicting the main scores, the scores that go from 0 to 3+ that we all assess in our everyday practice, subdivided in the lines below the images in the new labels that we attach to specific subgroup of breast cancer, from positive to low, ultra low, and we even think about now the concept of subdividing score 0 between null and ultra low. So as I always say, it has been really a story of success. Here, review in this beautiful book, The Emperor of All Maladies, you can really read the history about the first enrollment of a breast cancer patient in a trial dedicated to HER2-positive breast cancer patient by Dennis Lamon, and the first demonstration in the metastatic disease that addiction of an anti-HER2 addiction to chemotherapy really led to a high benefit for this specific subgroup of breast cancer. And these were carcinomas that we all know about. There is an amplification behind, so there is a genetic alteration that leads to a massive HER2 overexpression, up to 2 million of receptor on the tumor cells. We know, we've been studying that this leads to activation of tumor cell proliferation survival, and the possibility to have specific compounds is really key because this can be actually stopped in the tumor cells. So we have been working over the past 20 years about, being very good in not missing a HER2-positive breast cancer with this combination of immunohistochemistry and in situ hybridization for the detection of HER2 amplification for SCOR2+ carcinomas. Now we are viewing this cartoon in 3 different ways. So we have HER2-positive and HER2-negative disease, and in between we have a large amount actually of our diagnosis that goes up to 55% of all our breast carcinomas, newly diagnosed breast carcinomas, that is called and labeled as HER2 low. So we all know that it's all about a SCOR1+ or a SCOR2+ carcinoma without the presence of HER2 amplification. These are mainly luminal carcinomas, but you can also have a good degree of so-called triple-negative breast carcinomas that can have a HER2-low status. And so in a way, they have an important therapeutic option that has been demonstrated in the very famous DESTINY-Breast04 trial. Here you have the New England publication. So the step one was really to demonstrate that with an antibody-drug conjugate targeting HER2, that is trastuzumab deruxtecan, you can really have a benefit in terms of survival, not only progression-free survival, but also overall survival, if you treat your patient with this ADC compared to the choice of chemotherapy by the physician. Step two was to go a little bit down in the assessment of HER2 expression up to ultra low, and by this we mean actually breast carcinomas that have score 0, but that they still have detectable expression, detectable, I would say, staining in your IC reaction. And this was demonstrated in the DESTINY-Breast06 trial that has been recently published. This trial confirmed the data on HER2-low breast cancer and added a little piece of evidence on the fact that we have an advantage in terms of PFS also for the HER2 ultra-low population if we treat these patients with trastuzumab deruxtecan compared to standard chemotherapy. So as you can see, if we go back to our standard, let's say, scores and the way that we score HER2 in our daily practice, we are now entering in the very low levels of expression that are actually the score 0 carcinomas. So the DESTINY-Breast06 demonstrated a benefit in the ultra-low disease, but we also have the DESTINY-Breast15 trial going on that will see whether even in the null population, so those score 0 where we do not see any type of staining at the microscope, we still have benefit of trastuzumab deruxtecan for our patients. So I think this is the right time to introduce a concept, and the concept is that we really need to think that immunohistochemistry was not developed at the very beginning to detect very low levels of expression of HER2. So we really developed this assay to be able to identify the positives and the possible positives that are the score 3+ and the score 2+ that had to be then reverted to a reflex testing by in situ hybridization. So that's why, of course, having a score 3+, it means that we have millions of receptors on the tumor cells. Then you go down, you see there is a decrease in terms of presence of numbers of receptors on the tumor cells. But even in the score 0, it doesn't really mean that we do not have receptors on the cells. We do not perceive staining, or we perceive a very faint and very perceptible heterogeneous staining at our microscope. But it doesn't necessarily mean that we do not have receptors on the tumor cells. And this is something that, of course, also gives an explanation about the fact that there is still possibility to treat this patient with an antibody-drug conjugate that targets HER2, because there are HER2 receptors on their cells, even though at very low levels. But going down to this very low level of expression of HER2, it actually makes us think about, wonder a little about whether will HER2 expression matter in the future. Because if we demonstrate that even the score 0 carcinomas, patients affected by a score 0 carcinoma, can still benefit from this drug, then we really have to wonder whether we still have to subdivide all these carcinoma in positive, low, ultra low, and none. So starting from the fact that definitely the data that we have right now suggests that a minimal level of target antigen is really sufficient to elicit a response, I think we need to reason a little about on 3 points. So if we want to have a critical view of what we do in our practice, I think we need to reason a little bit whether the levels of expression, the degree of response to treatment is still something that matters. Whether we are good at assigning the labels of HER2-low and ultra-low disease in our samples, and whether a sample prefer to the other, to another sample, will actually make a difference in prescription of the drug, because this is something that is related to our world and our practice every day. So regarding the first point, I think that the data that we have right now are all coming from an academic trial that is this phase 2 DAISY trial promoted by Gustave Roussy in France, actually. In this trial, that is an academic trial, there were 3 cohorts. There were cohort 1 that was enrolling HER2 positive patients, so classical HER2 positive disease. Then cohort 2 was dedicated to HER2 low disease, and cohort 3 was dedicated to HER2 negative score 0 breast carcinoma patients. So if you look at the degree of response to this antibody drug conjugate, that is trastuzumab deruxtecan, of course, there is the response in the 3 cohorts, but the levels and the degree of response is actually different. So there is a kind of continuum of response related to the levels of HER2 expression. And also, if you look at progression-free survival of the 3 cohorts, cohort 3, that is the one related to HER2 negative disease, score 0, is actually that cohort that is performing worse overall. So there is a kind of prognostic stratification, even though there is a benefit from this drug. The second point that I want to comment, and I think we need to comment, given that we are pathologists and we are doing this job in our everyday practice, is whether right now there is evidence that we are good or not very good at assigning these HER2 low and ultra low labels. So for this reason, I'm referring to the latest data that we have that have been presented in a mini oral session at the latest ESMO Congress in Barcelona. So these are data coming from the DESTINY-Breast06 trial. So the trial in which both HER2 low and ultra low breast cancer patients were enrolled and treated either with chemotherapy or with trastuzumab deruxtecan. So what they did was to actually look at the agreement on the assignment of the HER2 scores between local assessment and central lab. So in this trial, every patient that had a sample with a score 0 that was assigned at the local laboratory could be enrolled and then reviewed at the central lab. So you see that there are discordances. Here are the results by the local pathology lab, and these are the results assigned by the central testing. So just to summarize up here, out of the samples that were scored IC score 0 at the local laboratory, 40% were reverted to ultra low label, and 24% were actually scored as HER2 low at the central lab. So this is a message for us right now to let's say dialogue a little bit with our oncologists, and if an oncologist actually is asking for to review a slide that is possibly an archival slide where we were not asked to be that precise in assigning score 0, ultra low and low, because there was no clinical meaning related to these subcategories, it is probably worth it to review the slides and reread it according to a new mind related to ADC prescription. The third point that I think is in a way important and maybe crucial in the future is related to the type of sample that we need to test. So let's go back again to the trial, because these are the data that we have right now from which we can, let's say, draw some conclusion. So in the DESTINY-Breast04 trial, the tissues that were analyzed could be actually any type of tissue. It could be a primary carcinoma, it could be a metastatic deposit. It could have been an excision type of surgical specimen or a core biopsy. And it could have been a archival slide or a new biopsy that was taken at the time of enrollment in the trial. So there was a mixture of samples that were used to assess HER2 and assign a HER2 low label to that specific sample. So what they did was to go back to the data and correlate them to response to treatment. So whether the sample was a primary carcinoma or metastatic deposit, they wanted really to see whether there was a differential response to this type of therapy. actually the data that we have right now are telling us that the efficacy of trastuzumab deruxtecan was actually consistent throughout the categories, regardless of the tumor sample feature that you could have picked up. But the thing that we don't consider sometimes is that HER2 low and HER2 ultra low statuses are a little bit dynamic overall. So here you have one of the papers that recently reviewed the correlation of matched samples in the same patient. So they studied cases in which there was availability of the primary tumor and the corresponding metastatic deposit that was available for that specific patient. And they assessed and they looked into specific HER2 scores in these two types of specimens. And as you can see, there is a shift from HER2 low to 0 and from 0 to ultra low in particular. So the assessment of these low levels of HER2 expression is a bit is telling us that is a little bit dynamic sort of dynamic phenomenon, and we do not have right now in the trial matched tumor samples between primary and metastatic disease from which we can draw actually any conclusions at the moment. But regarding type of samples, I think we can go a little bit deep because there are data coming from this worm autopsy paper. This is a paper describing 306 different type of samples from 10 patients with HER2 negative metastatic breast cancer. And one of the specific questions in the scenario of HER2 low and ultra low disease and the prescription of ADC was really to look into the specific HER2 scores throughout the samples that were available for that specific patient. So here you have the histograms that is actually with 10 columns, 10 patients, 10 columns, and each column has a different type of degree of the green that is related to the different type of scores. As you can appreciate here from the picture on the right, there are only patient 2 and patient actually 9 that are homogeneous throughout the column, and this means that actually all of the samples that the authors were able to assess for HER2, those specific 2 patients were actually homogeneously HER2 negative, whereas all the other patients had a different type of availability of samples, and these samples were actually different in terms of HER2 assessment. And even by focusing on a single, let's say, organ site of different metastases, if a patient had more than one metastasis in the liver, the authors went to analyze it, and they realized that different type of metastasis in the same organ had actually a different HER2 level of expression. So this is telling us about the fact that HER2 low and ultra low breast cancer is actually heterogeneous and the expression is dynamic. So this gives me the opportunity to show the fact that HER2 low breast cancer is actually heterogeneous. There has been a long debate going on about the fact on whether HER2 low breast cancer is a specific disease category, and we have a lot of data suggesting that it's not actually a specific subgroup of breast cancer, but this doesn't mean that within the big bunch of HER2 low disease, there are differences across samples. So I'm reporting data coming from my lab where we analyze at transcriptomic level here. In this, here you have the main results of our transcriptomic analysis on a cohort of 99 HER2 low breast carcinomas. And we performed transcriptomic analysis with the breast cancer 360 panel by NanoString, and we performed an unsupervised clustering analysis. By this analysis, we realized that there are at least 4 discrete groups of breast carcinomas within the basket of HER2 low disease. We called this classification LoRa, and as you can see, the acronyms mean and actually are meant to indicate a specific feature of the different subgroup of breast carcinoma that we identified. LA stands for lymphocyte-activated tumors. So there are HER2 low breast carcinomas that have a high enrichment in tumor-infiltrating lymphocytes and other type of mononuclear cells. U stands for unique HER2 gain. Those are breast carcinomas with HER2 low status that have reached the highest level of HER2 copy number, even though they do not reach, of course, the levels of HER2 gene amplification. Then there is the R category that stands for stromal remodeling, and this regroups a set of tumor that is mainly composed of G1 and G2 carcinomas with a lot of fibroelastotic stroma or with loss of adhesion proteins, so mainly lobular carcinomas. And then the A stands for actionable PI3K mutation, so a subgroup of HER2 low breast carcinomas that is rich of actionable PI3K alteration. We did not have data of a correlation, of course, with trastuzumab deruxtecan because this is an historical cohort, and still we do not have any relationship of these four subgroups with the response to treatment. But one may hypothesize that these different features of the stroma, of the genes, of the tumor microenvironment could have relevance, perhaps, in correlation with response to treatment. And I'm showing you some newer data from my lab. We presented this data at the latest ESMO breast cancer meeting in Berlin this year, where we performed a very detailed copy number analysis genome-wide in HER2 low breast cancer, and we actually identified a recurrent peculiar chromosome 17 copy number alteration profile that was also correlated to prognostic data, and here you can see the blue line identifies those carcinomas that are that actually show this unbalancing of chromosome 17, that is mainly a loss of the P arm and a large gain of the Q arm, and breast cancer patient affected by a tumor that is harboring this alteration actually doing worse overall compared to the other HER2 low breast carcinomas. Again, it would be very interesting to correlate this not only to prognostic data, but also to data in the context of treatment of antibody-drug conjugates such as trastuzumab deruxtecan. And these data led me to talk a little bit in the last part of my talk about whether we do have something else beyond HER2. So we do have the surface protein that is telling us that right now, if you have some degree of HER2 expression on the surface of the tumor cells, actually the patient can benefit most likely from this ADC. But not all the patients that have this feature will eventually, in the end, respond to this specific treatment. So 50% of patients in the end will benefit from this treatment. So do we have some other biomarker that is relevant right now and that could be perhaps in the future incorporated in our assessment to really identify and pinpoint those patients that may benefit from this type of treatment? Again, if we think about biomarker analysis correlated to response to treatment, we do not have many data right now. The data for breast cancer come again from the phase 2 DAISY trial, and I will show you what we have right now so that we deep a little bit our knowledge on possible mechanisms of either major response to treatment or resistance to this type of treatment. So the authors of the DAISY trial paper analyzed, first of all, levels of HER2 expression, and they identified in HER2 positive disease that actually when you have a heterogeneous breast carcinoma with different levels of HER2 scores in terms of score 3+, so either a homogeneously stained score 3+ carcinoma or a heterogeneously stained score 3+ carcinoma, then you have actually identified two patients that will respond differently to this type of treatment. And this makes sense because we do know very well these very highly heterogeneous tumors. They are rare, but we encounter them, and having less degree of HER2 overall makes actually sense that correlates with less response to treatment. They went on and tried to correlate some features of the tumor microenvironment with response to the ADC, to trastuzumab deruxtecan, but they didn't find actually much overall. And even when they went on genomics, so what they did was to perform a mutational analysis and to do a copy number analysis of the HER2 gene. They did not identify much, except the fact that if you have very high level of HER2 amplification, of course, you will respond better. They identified a hemizygous deletion that was affecting HER2 in some score 0 carcinoma that was actually correlated with less response to treatment. And again, given that we performed the copy number analysis in our cohort, I can tell you that actually among score 0 tumors, we also identified a degree of tumors that had this hemizygous deletion. And so this could be an interesting factor of correlation with less response to treatment to be investigated further. At the latest ESMO Congress, the group led by Fabrice André presented an updated biomarker analysis from the DAISY trial, and they focus a little bit more on the low levels of expression of HER2 in low and ultra low. So on one side, if we have data that tell us that if you have more HER2 in HER2 positive disease, you are bound to respond better. When you have low levels of HER2 and you go into the low and ultra low disease, even though the spatial distribution of HER2 low is actually different among samples, you do not find any type of correlation. So heterogeneity does not appear to be relevant when you have low levels of expression of the protein. Again, nothing coming out from the analysis of the tumor microenvironment. From the genomics, only the detection of a HER2 mutation that was close to the trastuzumab binding site was actually detected at resistance, but it was only one sample, so we really need more data. The data that are probably more promising are these describing an association between the presence of mutational signatures related to DNA mismatch repair and oxidative stress that were significantly associated with higher response to trastuzumab deruxtecan in HER2 low and HER2 score 0 metastatic breast cancer. So this is something that probably is worth investigating further on more samples. And let me just end this presentation by showing you that actually for trastuzumab deruxtecan we have a lot of data on breast cancer. We have some data also on other type of tumor, mainly gastrointestinal tumor, and some data on gynecological cancer. We have some data coming from tumor analysis, and actually I will show you that we have now a tumor agnostic approval for HER2 positive disease and this type of prescription of antibody drug conjugate. So I will exploit my last 5 or 6 minutes just to go a little bit beyond breast cancer, because actually treating with an antibody drug conjugate that is targeting HER2 has actually opened more possibility for more patients, even affected by other type of tumors. One of these is gastric carcinoma, for which we know that there is an amount of HER2 positive disease. And there is a phase 2 Destiny Gastric 01 trial that performs some biomarker analysis. They mainly focus on different measures of HER2, either HER2 by ISC, by RNA expression, by copy number in ctDNA, and so on and so forth. And what they demonstrated was that if you have more HER2 in gastric carcinomas, you are bound to respond better. And when they performed in HER2 positive disease a transcriptomic analysis with differentially expressed genes between responder and non-responders, they identified 57 genes that were more associated when overexpressed to major response to this type of treatment. And actually, it's interesting to see that the responder had actually a significantly higher expression of genes that are mapping to the locus of actually of HER2 of the HER2 amplicon. So in gastric cancer is really all about HER2, to the point that actually if you are HER2 positive in gastric cancer, you also have a HER2 mutation, you're bound to respond better. So patient with HER2 mutation and positivity for expression of HER2 are those that are actually the super responders in gastric carcinoma cohorts. And mutations are interesting because the response to antibody-drug conjugates such as trastuzumab deruxtecan and HER2 has been also correlated in other type of cancer, not to HER2 expression, but to HER2 mutation. This is the case of non-small cell lung cancer, for instance, for which we have an approval for when you have a detection of HER2 mutation, regardless of the levels of expression of the HER2 protein. And in the first pan-tumor analysis that they performed, as you can see, there were different types of tumors. Of course, there was breast, there was gastric, gynecological tumors. They went on looking for mutations, and they detected sometimes some mutation across these tumors. And regardless of the type of expression, they found actually a response, correlation with response to treatment. But the most interesting pan-tumor analysis is the second one that they performed in the Destiny Pan-Tumor 02, that is a phase 2 trial. Here they enrolled different types of tumor. The key point was to detect expression. And they realized that whenever you have a SCOR3 plus expression, there is a response to the antibody-drug conjugate trastuzumab deruxtecan. And these data supported the role of this drug and this biomarker, that is in the end a SCOR3 plus HER2 positivity, as a tumor-agnostic biomarker. And in April this year, FDA promoted the accelerated approval for HER2 SCOR3 plus solid tumors. So really HER2 became an agnostic biomarker in our different scenarios. So I think that the ADC, I do agree with this position paper by these key opinion leaders in breast cancer and beyond. I do believe that for ADC, the scenario is still very complicated, and we focus a lot on finding the minimal biomarker that we need, that is the biomarker that is maybe useful to prescribe the drug, but we need still to be looking a little bit into other biomarkers that can help oncologists tailor a little bit more the prescription of these therapies. Otherwise, we will prescribe ADC to anyone without really thinking in a critical way who is going to be the best candidate patient. So we do need collaboration. We do need more biomarker analysis in academic studies, I think, to understand more about ADCs targeting HER2 and mechanism of resistance. If we have to draw some conclusion today, and let's focus on breast cancer, I think that we have to face the fact that right now we are asked to best identify HER2 low and ultra low categories for our breast cancer patient, because there are therapeutic options that are available. We know that we are now becoming more expert on low levels of expression of HER2. So there is an awareness of rescoring and reassessment of HER2 that has to be raised for our breast cancer patients. But we need to keep in mind, as pathologists, I think that we have translational research in our hands. We can be players in this context. And we need to, given that we look at the samples, we see the difference across disease, and temporally speaking, from primary to metastatic disease, we need to contribute to translational studies that can really better define these scenarios. And might be that immunohistochemistry will be actually suboptimally for the future. We need to work on finding something else if it's actually useful for a better prescription of these drugs. And with that, I would like to thank my group that is focusing on translational research with me, and our breast unit working for our breast cancer patients every day. And thank you for your attention.
Thank you so much, Caterina, for an excellent presentation. So this is open for questions. If someone has any question, please post this in the chat. I don't see any questions yet. But in the meantime, I can ask you a question about the archival samples that you mentioned. Sometimes you are asked to look at the archival samples, and I have noticed, just like in H&E, the immunohistochemistry also fades. So is there a time period, that if the sample is more than 3 years old or 5 years old, instead of re-looking at the immunohistochemical slide, you should redo the testing.
Yeah, I agree. I think that depending also on the the type of archives that you have, the condition of in terms of temperature and everything else related to your archives, actually the stainings get a little bit old, they get bubbles, so it's difficult to reassess properly the archival sample. So I would suggest the first step is the easiest, is to retrieve the slide and have a look at it. If it's unacceptable in terms of reassessment, then I would just redo the testing by cutting a new session. I mean, if you see that it is still interpretable in terms of intensity, there is a good control, then you can go for it. Otherwise, I would just redo the testing. I did not comment on the different types of assay that we have for HER2, but we can add that in the registrational trials, it was the Ventana assay that was used to score these samples. So I do think that we really want to be strict related to, to be compliant with what has been done in the trial. The Ventana assay is the one that is suggested, even though there is not a specific, let's say, at least in Europe, there is not a specific restriction. I think that probably in the US, you also have the approval related to the Ventana assay. Is that correct?
Sorry, say it again.
I'm not sure whether, so in Europe, we do not have restrictions related to a prescription of a drug related to a specific assay, okay, that is used, except for PD-L1, okay?
So, but for TDXD, the protocol is locked. You cannot change anything.
It's locked to the Ventana, right? Okay.
Yes.
Yeah. So I would stick anyway to that, and I stick in my practice to that.
There are other questions, both in the chat as well as in Q&A. One question is, will the clone or platform matter for IHC testing for HER2 low?
Say that again, Will?
Will the clone or platform matter for IHC testing for HER2 low?
So yes, so I was mentioning before, just so there is a difference in terms of the, let's say, the different assays. There are a couple of papers demonstrating that there is a difference between the Ventana and the polyclonal HER2 DACO assay. So yes, there is a difference, and the HER2 DACO is actually looks like to be more sensitive. So the Ventana looks more, I would say, specific in a way, cleaner. So that's why the suggestion of the FDA is to stick to the Ventana assay, because it is the one that was used in the registrational trials.
There are two questions which may be applicable for people here in the US, sticking to the ASCO CAP guideline, but the questions are, do we write HER2 low or ultra low, or just score as 0 or 1+ in reports, as it is optional according to CAP format?
Yeah, I do agree with that. So in Europe, we also stick to ASCO CAP, and I totally agree with ASCO CAP that we do not necessarily need to add a note or a label on our report saying this is low or ultra low for two reasons. One, because for the HER2 low definition, if you have a score 2+, you still need to do the ISH testing. So it doesn't mean that with your ISC, your report that has the ISC scores, you are going to be able to define a HER2 low disease, okay? Second is because these labels that we're applying around now may be temporary. And I do suggest that the good point is to have the details on the scores and possibly the percentage of HER2 expressing cells that you see in score 1+, 2+, or in score 0, okay? So the only thing that I would add is to include in the score 0 the description of whether it's a score 0 so-called null, I do not see staining, or if you see some staining, you should say score 0 with staining, so that we are able to interpret the report and see that it is not a null, but it's an ultra low disease.
Yeah. a similar question, but it says, if someone is reporting positive, low, ultra low, and null, would that interfere with CAP ASCO accreditation? Would that be a problem in the future?
I think that it will be, let's say, it will be an interpretation is like, it's like writing luminal A, luminal B instead of the, reporting probably the IC scores for estrogen receptor and the rest. So it's more an interpretation rather than a description of biomarker that, of course, needs to be interpreted, but I think that the interpretation should be left to the multidisciplinary meeting. So I would discourage the fact that to write positive, negative, also because positive means at least two things, either a score 3+ or a score 2+ with amplification, that even though is in the end HER2 addiction is still different. And so yes, I do think that this is not appropriate. Also, it goes a little bit against what we have been doing over the past 20 years. So I would not change that much for a time in which we are still witnessing changes in this type of scoring.
There is one question in the Q&A section. It is, has there been any development on different antibodies with better sensitivity for detecting HER2?
As far as I know, actually, no, there are no other, let's say, assays that have been developed rather than methods probably of assessing HER2 with more, of course, using digitalization of slides and then having a scoring that is automated, or fluorescence type of, let's say, experiments that can be better quantified by image analysis systems, but not something related really to immunohistochemistry in bright field, other than digitalization and using a system that helps you count.
Just on that same line, do you know of any methodology that could be used to even quantify the receptors on cell that could be used clinically in the near future?
Well, in the paper that I mentioned in the slide where I was showing you the numbers of receptors on the tumor cells, in that paper they used it was like let's say a derivation from two methods. So they had cells that were assessed in flow cytometry, so that they could assess how much trastuzumab was attaching to the surface cells to the receptor of the surface cells, and then they derived the number of the receptors by comparing also the IHC score of the same cells. So it's a bit complicated to do in our daily practice because it's not that trivial. Well, no, actually, right now I don't have any clue. And actually, in the DAISY trial, they performed the analysis quantification of HER2 mRNA expression by RNA-scope. That is another method that you could use. It is in situ, and you can look at signals stemming from the mRNA. But actually, they did not find any difference in terms of responder, non-responders. So I do not know whether this could be something promising.
And I guess quantification would also be difficult.
Yeah, it is kind of challenging. Yeah.
There is another question posted. Please elaborate your experience of HER2 new fish on metastatic bone biopsy, especially when a case was 3+ pre-chemo, but 2+ on metastatic site.
Right. Of course, this is always a challenging scenario because it depends on how much the tissue has been decalcified, whether you use a mild decalcifier or not. So the thing is, first, I do immunohistochemistry and I see how it looks like, okay? Then, of course, if it's not 3+ that is clear on the examination, I reflex it to in situ hybridization testing. And then, honestly, I see whether the fish is interpretable or not. If it is, then of course you count reliably the signal and you see whether you reach amplification or not. If it's not interpretable, then I just stated it is not interpretable. Having said that, if you have a HER2 positive disease, or if you have a patient that has been labeled as HER2 positive because the primary tumor was a clear HER2 positive, either 3+ or 2+ amplified, you get a metastatic biopsy and it reverts to HER2 negative disease. To the clinician, it doesn't necessarily mean that they will shift to another type of treatment, because they know that there can be heterogeneity across metastatic deposits. So for clinician, it's always good if they can add something more, okay? If they have to take out a drug, then it can be difficult, and they do not take it off unless there is very strong evidence that there is a complete conversion of phenotype. But having said that, I think that in this context, the ADC come as an help, because of course, an ADC such as trastuzumab deruxtecan works really well in the HER2 positive disease, the typical HER2 addicted tumor, but has also evidence of performance in HER2 low. So in that scenario, it could actually, this type of drug could sort out tricky scenarios, I think, clinically speaking, in the end.
Yeah. So there are several questions. At some point we will have to stop, but here, if you have a slide with 9% or 11% of cells with faint membranous staining, which side do you go? Though with DB06 would make this not important as both eligible for treatment.
Exactly. So if it's really so between 9 and 10, about let's say around 10. Well, probably if it's around 10, if you look into the different angles of the slide, you will find some other cells and it will become 11, let's say. You also have the option of analyzing, if it's a large tumor, what I do is to analyze another block. Honestly, I do it. It's not on every single case, of course. If you have a score that is tranchant, let's say, so it's clearly a score 1+, you have a positivity in clearly more than 20, more than 30, more than 80%, of course I don't do it. But when you have borderline cases, it's always good if you have another block to test also the other block. If you're really, right now, if you really need to see whether it is a HER2 low or ultra low case.
Thank you. There is one question in Q&A. What is your experience with Cepheid's START4 biomarker assay, or STRAT4 by Cepheid? Are you aware of that?
I'm aware of that. I never used it actually, or used it some years ago as a test, let's say. Well, it's something different because it's based not on protein expression. So it's really another type of, say, it gives you another type of information. And right now there are no data on correlation between this and response to treatment. So it's something that needs validation in case it comes out that levels of mRNA expression are relevant in this context, and they perform as good as IHC. Right now, I would just stick to IHC because it's something that we do in our practice. It's much easier. We all know that very well. We just need to be a little bit more, let's say, precise in the lower ends of this spectrum.
Okay. And does the use of tissue-safe vacuum tissue modify the expression of HER2?
Well, actually, if you stick to the under vacuum and control temperature 4 degrees. So the key point, we've been doing some work actually related to that because the tissue safe was kind of created in Turin from my former mentor, Professor Bussolati. And so the key point is really the temperature rather than the vacuum. So if you need to organize your workflow at control temperature. So you need to organize your workflow at 4 degrees. If the cold chain is maintained, then you don't have any issues. But of course, if you go out of this path, this workflow, then there may be issues because, of course, a higher temperature would affect antigen preservation.
Yeah. There are just a couple more questions. How do I interpret HER2 low IHC with confidence when we have staining artifacts, staining of lymphocytes, etc.?
You need to be very critical, and you need to really look into, no cytoplasmic staining. You really need to look at the membrane. It can be rare, it can be sparse, it can be heterogeneous, it can be really faint, but it has to be membranous. So you really need to take out of your mind the fact that it is just, a blush that is going to be positive somehow. I see samples in which you go at, even at a panoramic view, you see a sort of blush and you say, oh, this may be positive in a lower end of expression. Then you go at higher magnification, you realize that it's just, as the colleague was saying, it's just artifactual. So you really need to go, it's something that you do at high magnification, first of all, and you really need to be strict and look only at the membrane of your tumor cells.
Just two last questions. One is your experience with RT-PCR for HER2, and then your experience with image analysis assisted IHC interpretation.
Okay, so for RT-PCR, other is related to copy number or mRNA expression. Again, I think it's something that goes, so I would not use this type of assay to look into HER2 expression, okay? I would use this type of assay to look for something beyond the expression levels of HER2. For HER2 expression, we have IHC clinically validated even in the lower ends of the spectrum. I think it's interesting to use another technique, and this also can complement the other question that I was responding to, the one of the CFA Stratfor assay. Other type of assays can be interesting to try to find something more beyond HER2 on the membrane and HER2 expression that can be relevant. But again, you really need to have samples that of patients that have been treated with this compound to make any type of correlation with response to treatment. So for the time being, they can be used, they can be explored in research studies. Just have in mind that, first of all, when you do an extraction of either your DNA or RNA, then you don't have your cells to look at. So you're going to have your tumor cells, you're going to have the fibroblasts, you're going to have the lymphocytes, you're going to have the stroma contributing to that. So this is going to level also a little bit your levels of expression, is going to lower, of course, your levels of expression. You need to keep that in mind because you're not just looking at tumor cells. And then it may tell you something interesting that is different from the levels of expression. For that, I welcome that when we have this type of data related to response to treatment. And for the image analysis systems, I have to admit that I don't have much of an experience with that. I know data from the literature that are a bit contrasting. So right now, I cannot say that we have something like a tool that is ready for, I would say, prime time to support us really, really well.
Okay, so we are almost at 11:30. So I would like to thank Dr. Marchio for an excellent presentation and Stein for answering all these questions. And there was also a question about CME credits. So right now we do not have any CME credits, but we can look that for the future webinars. We can think about that. And I just want to announce that we are planning to have many more webinars. Hopefully the next one in January, but we will inform everyone in due course. So please stay tuned, and thank you so much to everyone for joining. And again, Dr. Marchio, thank you.
Thank you.
That concludes our webinar. Thanks.